All right. My name is Kristen Thomas. I am a fourth year pharmacy student at Samford's McWhorter School of Pharmacy. I'm doing just a short presentation on gastrointestinal disorders that are found in neonates. This information comes from the NICU Primer for Pharmacists in Chapter 14. The two GI disorders that affect neonates are gastroesophageal reflux, or GER, and constipation. These two disorders can affect neonates' feeding tolerability, so it is really important that we address these in order for the neonate to obtain adequate nutrition. Regurgitation, or spits, as it's often called in the NICU, is a really common and completely normal process in neonates. There are characteristics that are often found in neonates, such as decreased lower esophageal tone, immature peristalsis, shorter esophageal length, and delayed gastric emptying that can contribute to GER. The peak incidence of reflux occurs around 4 months, but it usually resolves on its own. But true GERD is rare in neonates. The neonates with GER often present with anemia, blood in the stool, failure to thrive, food refusal, and vomiting blood, and sometimes swallowing difficulties. The risk factors include prematurity, congenital abnormalities of the CNS, GI tract, heart, lungs, and oropharynx. Neonates who present with GER are often seen with back arching during feedings, crying, and irritability, food refusal, regurgitation, or vomiting. And long-term signs and symptoms include poor weight gain and failure to thrive. We want to relieve the symptoms of GER without causing further complications, so non-pharmacologic treatments are first line. These include changing the neonate's body position by elevating their head, laying them on their left lateral side, and upright positioning can improve their GER symptoms. Their feeds can also be thickened, which can help in non-acid GER. Both intermittent and continuous feeds have been studied in reducing GER symptoms in neonates, but there have been no definitive results from these studies. Proton pump inhibitors and H2RAs are the two drug classes that are most often used because they can help with the healing of erosive esophagitis. Antacids are also used and are effective in treating the occasional symptom, but should not be used for long-term treatment. And prokinetic agents like Reglan or erythromycin are not recommended due to the potential for serious adverse effects. Constipation occurs in approximately 3% of neonates, and diagnosis of constipation can be complicated by a delay in meconium passing, which is really common in very low birth weight infants. Constipation is more common in neonates with neurodevelopmental impairments or very low birth weights, and there is usually a primary cause to constipation. Like I just stated, constipation is often a sign or symptom of an underlying issue, such as an obstruction or a hypothyroidism, and a physical exam may show a full abdomen with possible distension or palpable stool in the pelvic region. As with GER, our goal is to reduce the complications associated with treating constipation. And although pharmacologic therapy for constipation is usually pretty benign, we still want to use non-pharm treatments first, such as rectal stimulation, reinitiation of breast milk, or de-seeing medications that may cause constipation. Pharmacologic treatments commonly include glycerin enemas or suppositories. Barium enemas are usually used as a diagnostic test, but they can also cause stooling. And so GER, in conclusion, GER is a normal process in neonates, and constipation is usually indicative of underlying conditions. And with both of these conditions, non-pharmacologic therapy should always be tried before initiating pharmacologic treatment. And the pharmacist plays an important role in selecting appropriate medications to treat these GI disorders and identifying medication-related causes to these conditions.